Hi, I'm Ann Greiner, President and CEO of the Primary Care Collaborative. I want to welcome you all to our webinar this month, Recommendations and Reactions to the NASEM report, Implementing High Quality Primary Care. For those of you who don't know the PCC, we are a nonprofit, multi-stakeholder organization that unifies and engages diverse stakeholders, promotes policies, and shares best practices to support the growth of high-performing primary care, including the patient-centered medical home. We have about 60 different organizations that are a part of our membership, and we really work hard to realize a strong foundation of primary care, which is integral and critical to a high-performing health system. A couple of housekeeping reminders. All of your lines are muted, but we will be taking your questions. We have about 10 minutes at the end of our program. Many of you sent questions in advance, and we have looked at them. We will also be recording this webinar, and it will be made available with the slides within 24 hours. As many of you know, the NASEM report was released and presented last week, and we have an incredible list of panelists and experts who are going to respond to the report's recommendations. But first, we're going to ask Bob Phillips, who is one of the co-chairs of the report, to present those recommendations in summary form. I also want you to know that if you just couldn't get enough of this report and conversation around it, there are a number of other opportunities for you to avail yourself of, including a Twitter chat sponsored by Mathematica directly after this webinar, and a conversation this afternoon starting at 4:30 that is around primary care innovation with respect to this report that is hosted by Ariande Labs. And tomorrow, the Harvard Center for Primary Care will also be having a webinar. We've dropped links into all of those opportunities into the chat, so please continue to engage around this important report. So let me now introduce Bob Phillips. He is the founding executive director of the Center for Professionalism and Value in Healthcare at the American Board of Family Medicine. Prior to that role, he was the director at the Robert Graham Center, and prior to that, he was the vice president at the American Board of Family Medicine. Bob also practices part-time in a community-based residency program in Virginia, and is professor of medicine at Georgetown. Bob, let me turn the baton over to you. Okay, while we're waiting for Bob to get on, you can see there is the report cover, and I think we've also put into the chat a link to the report, and it is free, and you can also purchase it. There's Bob. Great to see you, Bob.
So sorry, my mouse decided to die on me this morning, today as well. So thanks so much for that introduction, Ann, and thank you all for joining today. I'm really looking forward to our panelists and to the questions you have. And Stephen, I may just have you advance the slides since they don't seem to be advancing for me. If you could go to the next one, please. So we had 20 members of this committee. My co-chair, Linda McCauley, is the Dean of Nursing at Emory University. If you could go to the next slide. But the 20 people who made up the committee were not just clinicians, although we had several of those. We also had director of a community health worker program, a CEO of a community health center, several state and federal health policy experts, an economist, 2 anthropologists, and a sociologist. So we were really trying to cover the waterfront of people who participate in primary care and who understand it. Next slide, please. We also had 17 different sponsors, which is very useful on this side of the work because you have a lot of folks invested in the product and in trying to move it along. Next slide. But it means we had a lot of interested perspectives on what the statement of task for the report could be. And it really boiled down to 3 things. One is building on the 1996, so the 25-year-old IOM report on primary care for an internal audience in the United States. The second was an outward-facing one because there is an international effort focused on primary healthcare right now. And the third, which is really unusual for National Academy reports, we were actually instructed to develop an implementation plan, not just a set of recommendations. And we'll talk about those a bit more in a moment. Next slide, please. And next one. One of the things we were not asked to do is relitigate the evidence for primary care. We did take a lot of time to update it, but one of the things that still stuck out very clearly is that primary care is the only part of our healthcare system that results in longer lives and more equity. In fact, there were a couple of studies that came out along the way while we were working from Harvard and Ariadne Labs, really showing the relationship between primary care and mortality. The other thing the report conveys is that primary care is weakening in the United States and eroding, particularly in underserved and rural areas. And while we have some shining examples, we don't have a lot of opportunity to scale them. Next, please. One of the things that's hindering us is the fact that while primary care supplies more than 1/3 of all healthcare visits, and in fact more than half of all outpatient visits, it is about 5% of total healthcare spending, which I know the Primary Care Collaborative has been a champion for. But it's lower than most countries, and it is really starving our primary care capacity to deliver on health equity. Next, please. Next, one more forward. One of the overarching messages of the study that I want to highlight is an updated definition of primary care. So the 96 report started with a definition, and we made sure that we contextualized this, brought this up to a more modern definition of primary care that really focuses on teams, a focus on equity, the ability to work across settings and modality now with telehealth blown up by COVID-19, and the need to get back to the roots of primary care, of working certainly with patients, but also in the context of families and working with communities. The idea of community-oriented primary care is a very strong one in this report, and we would love your reactions to the definition. Next one, please. I hope you hear a very clear, high-level message out of the report that the committee felt that primary care should be a common good, that it should, because it has such high societal value, that everyone should have access to it that wants it, and that we need a public policy framework to make sure that that's working and that there's accountability tied to it. Next, please. I will just say here that part of the implementation plan means building in an accountability framework. I'll talk about that in a minute. We really think we have an open policy window here because there is so much focus on equity and because of what the pandemic has revealed about the weaknesses of our healthcare system, and particularly the fact that there was no primary care champion in the federal government. We weren't written into the epidemic plans before the pandemic, and we were not a prominent feature of the strategies to deal with it until in the last month. So it really points out the need to have something built around primary care at the federal level. Next, please. I'm going to stay high level on some of our objectives, our high level recommendations. We only had 5 of them. If you could go to the next one, please. And the 5th one is really a wraparound. It's part of that accountability and implementation plan. So the first one is pay for primary care teams to care for people, not for doctors to deliver services. So it's really getting to a hybrid model of paying for primary care, getting away from volume-based fee-for-service as the main way to do it, so that we do have enough capital to deal with the needs of the patient that can't be accounted for in fee-for-service. The second was around access. It's that idea of a common good, that ensuring that everyone has high quality primary care available to them. The third was about workforce, making sure that we train primary care teams where people live and work, not just hospitals. The fourth is a piece that was missing from the 96 report, and for good reasons, but it's about designing information technology that serves the patient, family, and the interprofessional care team. And we've really not done that very well. And the fifth one, which I'll spend a little bit more time on, is really ensuring high quality primary care is implemented. Stephen, if you could advance to number 5, that would be ideal. So underneath all of these 5 high-level objectives, there are 16 lower-level recommendations. I encourage you to look at those. But the fifth one starts off with this idea of a federal champion, and we call specifically for a Secretary's Council on Primary Care to be established by the Secretary of Health and Human Services, with the goal of coordinating primary care policy, bringing together all the heads of the agencies for healthcare, and ensuring that we have adequate budgets to work with in primary care, and that we are reporting out to Congress and the public on an annual basis on the progress towards these recommendations. And we also recommend, under current authority, setting up a primary care advisory committee made up of stakeholders like you on the phone here, that we can give, not just help with the agenda, but the priority setting for that Secretary's Council. Next, please. In 2006, emergency medicine was very successful in building on 3 Institute of Medicine reports to get an Office of Primary Care Research on the NIH campus. Primary care currently gets less than 0.5% of NIH funding for research. And I should have said for emergency medicine, it was the Office of Emergency Care Research. We want to follow that precedent and establish an Office of Primary Care Research that doesn't have independent funding, but it's there at the table when these proposals are being developed across institutes to make sure that primary care is understood and incorporated. The funding focus is really on the Agency for Healthcare Research and Quality, which was mandated by Congress to be the focus for primary care research. They just never allocated any funding to that mandate. So we speak specifically to providing funding to that mandate. And the third one is that there should be a report card, and there should be referees. So the report card or scorecard uses existing data to create metrics for the recommendations in this report. And we're also calling on philanthropy to help assemble that scorecard, help bring the data together underlying it, so that we can, on an annual basis, show the country how we're doing on these recommendations. And that makes the public, that makes some of you the referees for helping understand, are we doing what we had intended? Are we accountable? And I think, Anna, I will stop there. If we could just go to the last slide, just to remind folks that of the 5 high-level objectives. And these are available on the website. There are issue briefs for each of these 5. And every Tuesday in June, we will be unpacking each one of these in a 90-minute webinar with panelists reacting to each of them. And we invite you to go to the link on the website and sign up for those and come listen and participate in that conversation too. Thank you very much.
Thank you so much, Bob, for joining us. Really appreciate that. And you know, first, I think as a community really want to understand what's in this report, and then obviously our next job is to figure out you know, which of these recommendations we're going to move forward and how we move them forward, obviously. So that's the work ahead. The panelists who are going to be reacting to this join us here. Let me begin to introduce them, because we really have an incredible set of panelists. First, let me introduce Cincy Hernandez-Casio. She's Vice President for Health Justice at the National Partnership for Women and Families. Hi there, Cincy. and she is currently a member of PCC's board of directors. She previously served as the founding director of Families USA, Center on Health Equity and Action for System Transformation. So as you can see by Cincy's bio, she's really been a leader in health equity, leveraging healthcare and delivery system transformation in order to reduce disparities. Next, let me welcome Patrick Conway. Many of you know Patrick. He is currently CEO of Care Solutions at Optum. He recently took that position. Prior to that, from 2017 to 2019, he was president and CEO of the Blue Cross Blue Shield of North Carolina. And before that, he had multiple roles at CMS. I was amazed at how many jobs Patrick had at CMS, but he was Deputy Administrator for Innovation and Quality, and he also was Director of the Center for Medicare and Medicaid Innovation. Great to have you, Patrick. And finally, last but not least, Kavita Patel is also someone who is well known to many of us here joining our webinar today. She's currently a non-resident fellow at the Brookings Institute. And previously, she was managing director of clinical transformation at the Center for Health Policy at Brookings. Dr. Patel is an advisor to the Bipartisan Policy Center and a member of the HHS Physician-Focused Payment Model Technical Advisory Committee known as PTAC, which reviews payment models and advises CMS on those payment models. Kavita continues to practice as a primary care physician in DC. She also served previously in the Obama administration as Director of Policy for the Office of Intergovernmental Affairs and Public Engagement in the White House. So we are really in for a treat, and Bob Phillips will also be joining us. He may want to augment or underscore or disagree with our panelists. But let me open it up by just asking all of you, just quickly, round robin, lightning fast, one word reaction to the report. And Cincy, I'll start with you.
So I'm going to cheat and use 2 words. And I also want to apologize to the audience for my very busy background, but that this is the realities of working from home in my son's former nursery. And my reaction is great start.
Wonderful. Patrick.
On target.
All right. Kavita.
I guess 2-part reaction, like finally, and what took you so long? Yes.
Great. Thanks so much, guys. Cincy, let's turn to you first. As someone who represents consumers and patients and whose work has focused on reducing health inequities, you know, the committee defines primary care as a public good and makes an argument that it needs to be available to all and adequately resourced and designed to improve population health and reduce inequities. What's your reaction to that argument? And do the policies in the report, you know, do you think that they go far enough to help us close equity gaps that have been made more severe over the last year with the pandemic?
Thank you for that question. And so at the National Partnership for Women and Families, we believe that healthcare with primary care as not just a center, but the foundation is not only a public good, we believe it's a right. And it has to be available to all. And that means that while insurance is essential, it is not enough. An insurance card is like a phone, you know, like a cell phone. It's only as good as the network it's on. And we know that the networks for a lot of communities are simply not good enough. So we want to focus on how we make sure that the card gets you the right care at the right time by the right provider. And in our mind, the primary care provider is at the center of that. So as we rebuild our healthcare systems and our economy and our communities now, we need to ensure that we do better. And that means that we need to approach this opportunity to build in equity by design. And equity by design means that we need to pause and interrogate our assumptions about how and when and under what conditions people are trying to get the care that they need, including in primary care, and ensure that we are not unintentionally making things worse for people, especially in those communities that are systematically under-resourced and structurally marginalized. So to do that, we need to solve for the hard case, because if you solve for the hard case, the most challenging patients, the system will work for everyone. And I think that this report does an excellent, excellent job of including the need for equity in its narrative. And it is also critical that as we look at the specific recommendations, that solving for equity is explicitly centered in all of these, in all of the recommendations. So let me just go one very quick example. Take payment, which is an area that I've been really focused on. And yes, absolutely, we have to pay for teams and not just things that we do to people. And those teams need to be multidisciplinary, not just in terms of clinical providers. And also we need to have payment systems as we're evaluating that we're not just looking at short-term cost savings, that high quality primary care is defined in a way that centers equitable care. And so those are, and there are ways that if we, for example, shift from FFS, from fee-for-service to capitation too quickly, that we may actually inadvertently increase inequities because there are not necessarily the providers that are needed across, that are able to survive and thrive in a value-based system because of the generations of under-resourcing in those communities and for those kinds of providers. And I'll stop there so that other people, so that we can continue the discussion.
Thanks so much, Cincy. And while Bob describes this as an implementation report, I think we have to think about, it's an implementation report for NASEM, but truly to implement, I think we need to consider some of the questions that you've raised when we work on the payment recommendations. So, and that's really where, when we get to true implementation, at the point of care, there's a lot of issues that we'll need to resolve. Patrick, you've led CMS and CMMI and have had major leadership roles in health plans. What do you think about the NASEM payment recommendations directed to teams to both increase investment in primary care and move rapidly to capitation?
Yeah, so a few thoughts. I think, as I said, the recommendations are on target more specifically, and then I'll give a few examples. I think for primary care, you need increased investment, i.e. increased dollar investment. It should be done to focus on equity, social determinants of health, real population health management. In my experience, you want to get to a place where over half of that payment, if possible, on average, is through population-based means, so non-fee-for-service means. And I think you want to do that across public and private payers. I'll give you 4 quick examples. CMS, if you go back to the CMS innovation models, I think we learned a lot from comprehensive primary care, CPC, and then CPC-I, the follow-on, and CPC Plus. I think we also probably underinvested a bit. Quality and experience did improve. Cost, I think, obviously unclear. I would still view that as a learning and a positive, and I think it sets a foundation for sort of public and private payers shift in payment. As a physician, I've practiced for 20 years, mainly as a pediatrician, mainly as a hospitalist, but in North Carolina, I actually ended up volunteering at a federally qualified health center, which brought me back to my primary care roots, and it showed me that the system is still fairly broken, and there's a huge opportunity to invest in the system and caring for everybody. Also in North Carolina, we invest in primary care and moving to over half of the payments in these payment models. And last, in my Optum role, I lead a bunch of our businesses in care delivery. We have over 55,000 physicians now. We are moving to a capitated type model, a population-based payment model, because it enables those clinicians at those care teams to care for their patients in the way that's best, focused on quality, experience, and lower total cost of care. And we see that demonstrate positive results for patients, for people, for individuals and families, and the health system.
Thanks so much, and thanks for kind of weaving into your remarks issues that Cincy raised around equity. Patrick, I get asked this question all the time, but I don't have the authority or the decision making. I'm not in that kind of role to actually influence what health plans invest in primary care as a percentage of total cost of care. So when you get asked that question, how do you respond? What should they be investing?
Yeah, and I don't lead the health plan side of our business anymore, but when I led a health plan in North Carolina, I said over 10% in primary care. I actually think there's evidence both from the US and certain states that have mandated this and internationally that that's probably about right. So 10% plus. We weren't there in North Carolina started. We started getting to the 10% level and we're on that trajectory.
Terrific. Kavita, so you've been on the Hill and you've been in the White House, and there's a number of recommendations that really focus on the federal government, including to establish a Secretary's Council for Primary Care, to aid in integrating policies across all of the agencies, and also some recommendations related to accountability. Can you reflect on those, and given your experience, what will it take to make those recommendations effective?
Yeah, thanks for having me. And if you saw me a little distracted, it's because I've got a small person who keeps trying to enter into the shot. So I'm hopefully, hopefully kind of convinced her that she doesn't want to be embarrassed on a webinar. But I think so. My concern is that it sounds very good. And by the way, interagency cooperation, I think you would talk, Patrick led a very large agency. I think you would have every agency head agree that that's kind of what they hope they do on like regular business, but clearly the report, and I'll confess, I read the executive summary. I did not read all hundreds of pages. What the report highlighted is how without this very explicit concentration and integration and emphasis at the White House level, that it's just going to get lost. And I think that that's an incredibly valid point. The devil is always in the details, however, and the details don't lie in the NASEM report. The details lie in kind of what guidance is given to agency heads. It's not like even when Patrick ran CMS, I imagine there weren't a ton of instances where he could kind of go outside of, some of the boundaries that are created between agencies for reasons that actually have a lot of valid rationale. So HRSA and CMS to FDA to CDC. The report did a nice job kind of highlighting why it's so important and why it's important for it to not just be at Health and Human Services, which I also completely agree with. Where I think we still, it's so easy for me in primary care. Patrick spoke to kind of his practice in pediatrics. It's so easy for us to see what's wrong kind of when you're in it and the thick of it. And then it gets really hard to elevate kind of what needs to happen. So I don't want someone kind of in the secretary's office to be designated as kind of and I'm being euphemistic, the czar of primary care. I know that's not what the report recommended, but you could have that. And that individual, if they don't have kind of a direct line to the Office of Management and Budget, and they don't have a way to impact, CMS has just as part of doing like the work of Medicare and Medicaid beneficiaries, they have to get guidance and regulate. They have a timeline. Getting that interrupted, having some of that delay actually costs beneficiaries, and that's not fair either. So I think the question is the better question to me that this raises is there a will at this level? Maybe it's not at the Secretary's office, maybe it's not at the White House, but maybe it is. Is there a will to build into kind of what we do normally in individual offices, agencies, and divisions, kind of just like what they're trying to do in the Biden administration on racial equity? Is there a will to really think about primary care across those same kind of buckets? And I think that's actually where, hopefully in the execution of this, it should be directed. I also think there's a challenge. I don't know if we didn't get into this and we don't need to. It's very important for members of Congress to understand this. They take a lot of pride in having, kind of the front-facing role of advocating for their for their constituents, a lot of whom are primary care and health systems and community practices. And so how do we communicate? I know NASEM does that well because Congress calls on NASEM to do things, but sometimes in these briefings, those of us who are in it 365 and we kind of don't know how to explain it. So I think it'll be really compelling to paint a vision of what does this integration in the White House look like and how does it make a difference?
Terrific. Patrick, I don't know if you want to add anything to that, given your prior role, but you were doing a lot of head nodding, so I wanted to give you that opportunity if you do.
I always nod my head. It's been commented on, even sometimes even if I don't agree with you, but it's my natural tendency. But I do agree with that. No, there is like a devil in the details part. So there's a natural tendency we want to elevate this function. And look, I agree with the recommendation of elevation. I agree with everything Kavita said. Then I think just as you work through implementation with this administration and future administrations, what's that really going to mean? Who's going to do it? How do we translate that into the various agencies? What are the authorities? Like I tried to move payment into primary care, honestly, when I was at CMS. We did move literally billions of dollars. I will also tell you it was harder than you might imagine because you had to do the work of like what codes, what are the, we got to go through this process and there's rulemaking. And every time we add money for primary care, it takes money from specialty care. And then the specialists are upset. Like, how do we respond to that? I think I agree with what Kavita said. And now it's just the work that, of how do we implement that, piece by piece, section by section, if you will, across the policy apparatus.
Right.
I think Patrick,
and we know that this is, go ahead, Cincy.
I think Patrick brings up a really important point about the zero-sum game nature of some of implementation and the devil, the details that can be extremely devilish, right? And I think that in the same way that we're thinking about the fact that we need to let's just be really concrete and clear that we need to redistribute from specialty care to primary care, that is not just good for the economy, that is good for patients, and that is good for the long-term health of our population. There is a similar need for redistribution around in the equity spaces around the places that, and when I say equity, I am centering racial and ethnic inequities, but also rural, right? Like there are other and other areas that have been systematically under this system of payment and trying to let the markets figure it out, that are failing a lot of communities. And so figuring out how, not as we're redistributing resources towards primary care, we are also very mindful of further redistributing resources for primary care in the places that are really missing, right? And this is where my experience, like my father was a primary care physician. He founded the school, Department of Family Medicine in University in Puerto Rico. I worked in his office. I know the struggles of being a small provider for a community that is continuously marginalized and not having the resources to do something as simple as, how do I get an electronic medical record set up, right? And so if you don't have that, you are not able to do anything in value-based care. And so making sure that we are solving for how do we level everybody up so that they can exist and thrive and continue to provide high quality, cultural congruent care for communities that desperately need it. Because let me tell you right now, when he retired, nobody took his place. So, that is a huge issue that we need to ensure that we're not forgetting. We can't be looking at just, on average, are we doing more in primary care? And have that average, when you look into it, be that, yeah, there's more primary care in places that already had a lot of primary care, and we still haven't solved the problem where there isn't primary care, or where the primary care is not high quality for reasons of resources, not the intentions of the doctors, or where primary care, where there is a complete lack of congruence between, the backgrounds and the orientations and the language and the cultural understanding between the provider and the patients that they are trying to serve.
Thanks so much, Cincy. And I think you anticipated a lot of the questions that came in before we even opened up today's webinar, so I appreciate that. Now we're going to do some very quick polls that I think are going to help inform the community that's working on implementation. And so, Stephen, if you could put those up, I'd appreciate that. And there's just 2 quick questions, and thanks so much for participating. We've got upwards of 330 people on the webinar today, so we're looking forward to your responses. Okay, perfect. There we go. Thank you for that response. Teams, payment comes out first in terms of the most important recommendation. Thanks so much for that. And on to the next question. Okay, well, this was much closer, really not that much daylight between the recommendations focused on the federal government versus payment and support for the primary, for the training recommendations come in about tied for second. Thanks so much. Okay, now back to you, Cincy. You know, the updated definition of primary care focuses on a sustained relationship. While we know digital health and some new of the primary care entrants are really focused on access and convenience over relationships. How do you square the two? And, you know, are there any, does this depend on populations, different patient preference, the kind of care needed? Be curious about your response.
Forgot to unmute myself, and of course, webinar would not be complete if somebody didn't say that at some point. And this, I think this is a really important question because on the one hand, they are not at all mutually exclusive, and they can be really reinforcing for each other. So you can, if we think about digital health as a modality, like just another tool in a provider's toolbox to be able to continue a relationship, to build a relationship with a patient, you know, that is very, very powerful. And that is very powerful, especially for people who have many different challenges for being able to get themselves into a doctor's office, right? At the same time, we have to be very careful of understanding that digital health is not something that is equally accessible to everybody, right? There are enormous problems with just having a broadband infrastructure that can support this. Even if the infrastructure is there, there are enormous problems with the resources that individuals and families need to be able to access it, from whether they can even afford it, to do they have the hardware for it, are they comfortable with dealing with something as you know, sometimes fraught as their own health through a platform that they're not 100%, you know, sure that they trust, right? But fundamentally, we need to make sure that it is up to the patient, that there is patient choice. But we also need to understand that not everybody has all the choices to make, right? That it's not the same. Like, some people are able to make good choices or better choices and have a lot of choices at their disposal, and other people simply do not. And then the last thing I would say that we need to make sure as we advance digital health as much as possible, and especially build on the flexibilities and the that came from the COVID pandemic, and getting more telehealth available for people, that we don't inadvertently create a two-tiered system where for some people the only option they'll have is telehealth, because we have stopped investing in building, in real life, especially in real life primary care in certain areas for certain communities, because we're like defaulting, well, at least they can have the telehealth, right? And that wouldn't be, I don't think that is necessarily unlikely, given how these are the same communities that over generations have been disinvested in.
So important warning as we think about how we move into the future. Patrick, I'm curious what your reaction is to the argument that's laid out in the report that the focus of primary care payment and delivery reform should be more on on improving and closing gaps with respect to inequities and improving population health, rather than on cost reduction.
Yeah, so I think leading with the equity issue makes sense. Obviously, we've known it's an issue in our health system for a long time, and the last 12 to 18 months has demonstrated it even more stark relief, unfortunately, and see that in practice settings as well. So I think that focus is on target, appropriate, and we need to make those investments. And you've heard the current administration talking about that. I do think it's an and, though, to be direct and honest about it. I think if you're an employer, we serve a lot of employers, they care about cost because it's it is an effect on their bottom line. They also care about access and quality, et cetera, but they care about cost. For our nation, there's a cost problem. I think we can invest in primary care and actually help solve that cost problem, to be clear. But we need to continue to prove that out. How do you make those investments in primary care that both address equity issues and improve quality and experience, and over time lower, or at least maintain or lower the cost trajectory?
And it may be also a timing issue. I think, some of the research that's been done and some of the research that PCC has done, it can take 4 or 5 or, a number of years to really get the kind of gains on the cost front from some of these.
I'm glad you raised this. I know we want to go to others, so I'll be super brief. When I started at the Innovation Center, models had a 3-year evaluation, and it was like, there's no way that's the right brain frame. We got up to sort of 5 to 7. I still worry that these are large, complex systems, so we need a much longer time horizon to think about investing in health, and those trajectories are going to be significantly longer, and we need to think about it and measure it that way. I totally agree.
Gotcha.
I'd love to jump on, and if you allow me, but Patrick is 100% right. Like, we need to widen the aperture of what we're seeing as savings, and also redefine, right? The wrong pocket is going to continue to be a problem because, so for example, like if you're investing in primary care now or in pediatric care now, let's say, you're not going to see the results for 10, 15, in many cases, 10, 15, 20 years. And then we also need to think in what for many is less tangible, but it's no less real. I don't know how CBO would score, I don't know how that CBO can score this, but let's consider that right now, the majority of our children in this country are children of color. If we want in 10 or 15 years, when they're going to be out in the workforce, to actually be globally competitive and to have a thriving economy, we need to make sure those kids are healthy. That is not a bunch of specialty care, right? That is primary care front and center. And we don't have a lot of time to figure that out. But we do need to make sure that as we're trying to figure it out, the people who hold the purse strings are looking at more than short-term gain or short-term savings. They're looking at like, will I have people to hire for my business 10 years from now, right? We already know that's a huge problem with the military. Like, the military is having a huge problem recruiting enough volunteers because we're just too unhealthy. And so we're going to see this across all of industries and our economy in general.
Thank you. Speaking of children, Kavita's little girl, I think, was requiring some attention. So she has exited stage right, and we hope that she will be back. And we all have experienced this, you know, in this work from home situation where home takes precedent for a moment. I don't know, Patrick or Cincy, if you feel equipped to respond to the question I was going to ask Kavita about, you know, how do we diversify our primary care workforce so it's more reflective of the population that it's serving, and also how do we attract more folks to primary care? There were some recommendations in the report. Would either of you like to reflect on them? And if not, we can also ask Bob, because he's read every word of this report a couple of times.
Yeah, well, I want to know what Bob thinks, but I'll be super brief given I want to hear from Bob. You know, I do think making primary care the preferred path for not just physicians, clinicians of all types, and the care teams that we need and the interdisciplinary teams. I will tell you, when I was in medical school, went into pediatrics, that was not encouraged by my supervisors. Like, why, Patrick, you're junior AOA, why don't you go do surgery or orthopedic? And you're like, because I want to do pediatrics. And so, you know, I think there's some cultural changes we need. I think there's probably some financial arrangements that need to be changed, more community-based training models. So I'm actually involved in some, been involved in some companies over time in different areas like mental and behavioral health, where they have true community-based training models that then train people from the communities to work in those communities. So that's a few thoughts, but I should let Bob, who's smarter on this, answer.
And I'm happy to also reflect on that. But Bob.
No, Cynthia, please.
Okay, so this is extremely important. Number one, I do believe that it is essential to have more places where people can train. I went through the very, very challenging back when I was first starting working in health policy, working with the governor of Puerto Rico, where we were literally graduating more students than there were residencies in Puerto Rico, right? And so they would leave because they had to, and they would never come back. Right. And so if we don't have, and you can say the same thing about any community in the United States, that if you do not have the actual ability to train, you're likely not to be able to come back. And you're also, even if you do come back, if you didn't train in those communities, you're going to be missing an incredible amount of information and skills, and especially the problem solving that needs to happen in these under-resourced communities to be the best possible doctor that you can be. And so being able to have more than just hospital-based training opportunities, like my dad would have he was a one-off doctor, but he still had a training, like a slot for his students in his office, because there's nothing that compares to that, right? And so that's essential, but also I think it's important to understand that across all healthcare, there's an enormous disparity in terms of the racial and ethnic makeup of all sorts of different clinicians. And that is a much bigger problem that has to do with, you know, how long and whether people feel they can get into the level of debt and then still, like, you know, be there for their family and for their communities. That has to do with the lack of any kinds of real viable pipelines. And the pipeline doesn't start in college. The pipeline needs to start way before. So to make this real, there needs to be a lot of additional investment. And this is particularly where I think that interagency, interdepartmental work at the federal level needs to happen, right? Because this problem needs to be solved in education, in elementary schools, in middle schools, and high schools, right? So how do we make that happen? So that's just one example, but it's incredibly important.
Bob.
Well said, both of you. Thank you. I agree. I mean, Patrick, to your point, the way we value primary care clinicians versus others, it's a payment issue, but it so influences the culture about valuing those professions. It has such a perverse effect that until we fix payment, it's going to be hard to fix it in the training pipeline. But since you're right, the upstream need to work on diversity and helping people of color, of rural backgrounds, see the capacity to come to college, much less come to health professions training, is so critical. We're losing diversity in colleges right now, and that's going to affect who comes into medical school or nursing school. The locations of training is such a problem too. The overwhelming evidence that having trainees work in rural areas and underserved areas, it was so, the evidence is so good that it influenced the development of the Teaching Health Center program at HRSA. And that $500 million of funding is so critical. And it turns out it's the only piece of $19 billion in federal investments in training physicians that has any metrics, any outcome metrics, any accountability matrix. And so there's such an opportunity now to look at what are the products of $19 billion a year in training, and how do we change the products? How do we move the training model? How do we move the folks coming in to influence the ability to put more people into primary care and more people into underserved settings? It is just so essential. CMS says they don't have authority, and so we baked into the report that needs to change, that Congress needs to give CMS not just authority, but direction for how they evaluate their investments. I'll stop there because, Anne, I know you had other questions, but we spend a lot of time on this in the report.
Thank you so much, Bob. And I encourage all of you to put your questions into the chat, because I think we are opening it up to answer your questions. And as part of your response, I'm directing this to our panelists. You can start with just your closing message, because I know that was going to be part of what I asked you at the end, but I also want to make sure we get in answers to questions that have come through. One of the questions is around oral health, and you know, the person who asked it felt that it didn't really get the attention that it needs. The mouth is obviously a part of the body, and we have this kind of division that exists in our health system. So, you know, Bob, to you, how does that get incorporated into the recommendations of the NASEM report, and where does oral health fit in?
So oral health was part of our direct charge. One of our sponsors made it an explicit thing for us to focus on, and we do. And to Cincy's point, you need to be able to get people to the right person at the right time. And in many communities, that will mean oral health. And there are good models of integrated oral health into primary care. Now, not every community will need that, but the communities who do, it should be there because they have no other access to oral health. And having that shared infrastructure and a common sense of ownership of that community can be really powerful.
Thank you so much. And this is, yeah, go ahead, Cincy.
I would add to that just to kind of reinforce what Bob was saying about that there's some communities, some models of integrated care across the board that are really, really powerful, especially like community health centers that are in rural areas. I've seen some incredibly powerful models in New Mexico where there are like the community health center has 4 departments: physical health, mental health, oral health, and family support. And that's where the community health workers live. And that has been extremely important, and they're equal, right? There is not one that's subordinate to the other, and when they have to, they do group, they do team meetings to figure and conferences when there's like issues in a family or with a provider. And another space where we've seen really interesting examples of this is in the area of the urban Indian health centers and some of what the tribes have been doing as well, because they realize that they need to be able to provide, especially looking at rural areas too, like that there needs to be one place, like there is one place that people need to be able to go and one-stop shop because of all the geographic challenges as well.
And I also want to thank you so much for that, Cincy. Many of the exemplars that you just mentioned are captured in a PCC report about primary care and oral health integration that we issued last month. Well, there's Kavita. So glad you're back, Kavita. So if Stephen, if you can put that link into the chat, that'd be great. Literally hundreds of examples of where this is happening. Now I think we need policy to really spread those exemplars to something that is, more pervasive across the country. So we're now taking questions from folks who've either sent them in advance or are just putting them in the chat now. One question that came up, and Patrick and Kavita, if you could both answer this, and we'll go to Kavita first, is, practicing physicians, nurses, PAs out there, what can they do Tuesday to start implementing recommendations in this report?
Yeah, I'll start, and I apologize. I had to use a heavy amount of Hello Kitty to get some quiet in my household. So when Hello Kitty's a solid. It worked on me when I was a kid too. So I thought a lot about this question because I struggle with it myself every day. I think it's, to be honest, I think it's actually calling out and identifying kind of the unacknowledged work, like in the polling, that it wasn't shocking to me, and that the highest polling on, paying for kind of care services and kind of teams, that's not shocking because that's all we do. Everything and everybody who's watching, who and Patrick will commiserate, and so will Bob. It all kind of just rolls down to you. There's like nobody, even if you have scribes and MAs and community health workers, it's inevitable that you feel like it all comes down to you at the end. So I think actually one of the original studies I did back when Patrick and I were like health services research fellows was to actually do like a time and motion study watching primary care physicians and how much of their time was spent in indirect care activities. And it was like shocking then in a publication that we said that about 65% of clinicians' time is indirect. That was important. People were shocked by it, but no doctor I know is shocked by that. And so I think it's actually helping to define, even at an individual N of one basis, what it is that you're doing that you believe kind of delivers value, but doesn't tuck neatly into an E&M and CPT code.
Thank you for that. Patrick, did you want to weigh in? We are really getting to the end of the hour, and actually, instead of allowing you to weigh in, I'm going to ask each of the panelists if they have one parting message for this group, because clearly this conversation is going to continue. It will in the programs that I outlined earlier. So, Patrick, parting message for the primary care community as we digest these recommendations and think about going forward.
3 things. 1, I remember that study, Kavita. Thank you. 2, we didn't talk a lot today about mental and behavioral health care. All of our businesses in that area report to me, and it's a huge opportunity to do better for our nation and for people we serve. So we'd call that out. And then 3, related to the last question, I'm in my second mountain of life. There's a good book by David Brooks on that. And I still try to mentor people. What I often tell them is just work on the positive change in the part that you're in. So my first job was 1 unit with a nurse partner, in your clinic, your community, wherever you are, make that your mission to make that part better. So I'll end with that.
Thank you. That's great. Cincy, last comment.
So what I wanted to say is that none of this will work unless we have the data that we need to be able to actually measure, and especially disaggregated data by race, ethnicity, subgroups within that, because let me tell you, maternal health outcomes and infant health outcomes for Puerto Rican people are very, very different than for Mexican Americans. And that is getting lost in the average. And that's even worse when it comes to Asian Pacific Islanders. So data, we need to ensure that we're getting the right data, that we're measuring, not looking at not just the averages, but the actual stratified results, because otherwise we're never going to get to a place of equity. And it's just going to be guesswork or things that we know instinctively, but we won't be able to measure it.
Thank you. Kavita, and then we'll go to Bob for the final word.
I'll say, because I was absent, I'm going to say something incredibly provocative, and then if the tweet chat is next, I'll participate. I want to see primary care be forced to be on every presidential candidate and president's agenda. And that's not going to happen like namby-pamby because we think primary care is so good and we have all these reports telling us primary care is so good. It is only going to happen if we kind of, the business sector weighs in. Patrick's doing it and leading by example, Bob is doing it, Cincy's doing it, but we need to have, Mark Benioff at Salesforce. We need to have kind of all sorts of people, donors, all the way to political figures, feel like they're in a corner unless they can talk about why and how what they are going to do to make primary care better. It is no longer acceptable to be tucked in neatly into like a subset of policy papers. It should be something that is expected to be on every Democrat and Republican National Committee platform. So there's my mic drop moment.
I love it. I love it. And Bob.
Well, I think Kavita summed this up so nicely. I think we need to be clear about how primary care is not just a subset of healthcare, that it is essential to the success of our businesses, that it is essential to achieving health equity, and that with 1,000 whole county health professional shortage areas that have not budged in 20 years, it is about infrastructure. So I think we need to be able to tie it to the other key priorities and make it clear. This is why this is critical to the success of those priorities, to build in the inclination to make it such a high priority as Kavita was teaching me today in HHS and at the White House.
Thank you. And the PCC will be calling on all of you as we work with the community of stakeholders to move this agenda forward, because the time is now. So thank you so much for joining us. Thank you everybody for tuning in. We'll have this up on our website in less than 24 hours, and see you soon. Be well, be safe.
Thank you.